Assalamu alaikum. I am Dr. Istikhar Sajjad, SR Pulmonology, Faisalabad Medical University. Today's topic of discussion is pneumothorax. So first of all, what is pneumothorax? It is the presence of air in the pleural space. Normally there is no air between the two pleura, that is parietal and visceral pleura. But whenever air comes there, this would be labeled as pneumothorax. If we classify pneumothorax, there are two major classifications, that is spontaneous pneumothorax and iatrogenic pneumothorax. Spontaneous pneumothorax is further classified as primary spontaneous pneumothorax or secondary pneumothorax. Primary spontaneous pneumothorax occurs in the patients with no history of any lung disease. Among these patients, smoking, tall stature, and the presence of apical subpleural blebs are a major risk factor for the development of pneumothorax. There is the leakage from the smaller airway which might close spontaneously, and air fills up in between the parietal and visceral pleural layers, and it produces COPD, it produces pneumothorax. Secondary pneumothorax is the pneumothorax which develops in the patients who are having underlying primary lung diseases like COPD, emphysema, cystic fibrosis, bronchiectasis, lung malignancy, or interstitial lung diseases. Anyone who is having primarily his lung disease and develops pneumothorax, it would be labeled as secondary pneumothorax. Iatrogenic or traumatic pneumothorax is caused by some traumatic injury like in road traffic accident. Whenever sometimes there is a rib fracture which damages the lung parenchyma and develops the pneumothorax. Similarly, sometimes while some doctor or any paramedical person who is having a pleural tap, and in that procedure it causes lung injury and air leaks from the air and comes in the pleural space, this would be labeled as iatrogenic pneumothorax. Spontaneous pneumothorax is further also divided in three ways. One is closed type of pneumothorax. In this type of pneumothorax, there is an injury in the visceral pleura. Air comes from the lung between the pleural spaces, but that rent automatically seals off. So, there is no communication between this space and the lung. There are high chances that this air may reabsorb spontaneously or on itself. In this type, there is mean pleural pressure is in negative. In open type, there is a rent in the visceral pleura and it remains open. So there is a communication between the airways and this space. Usually these type of pneumothorax does not improve spontaneously or on itself. In these patients, the mean pleural pressure is equal to the atmospheric pressure because there is a communication between the atmosphere and this pleural space. Third type is tension pneumothorax. In tension pneumothorax, there is a valvular mechanism at this rent. This valvular mechanism allows that whenever patient inspires, the air comes from the airway into the pleural space, but when patient expires, this air in the pleural space does not go back via these airways. So the volume of air increases rapidly. This is called tension pneumothorax. In this, the mean pleural pressure is positive or higher than the atmospheric pressure, and it shifts the mediastinum towards opposite side. Most common clinical feature is the chest pain. This chest pain is pleuritic in nature and patient feels pain when having deep inspiration. If there is a tension pneumothorax, there is severe shortness breath and patient is having that shortness breath which is sudden in onset. If it is closed or open type of pneumothorax, patient may get shortness breath on walking, but is not in usually severe shortness breath. When we auscultate such patients, there is a decreased or absent air entry in that hemithorax with hyperresonant note. There might be tachycardia, hypotension, cyanosis, and tracheal displacement away from the side of the silent hemithorax and bulging of the hemithorax in the patients who are having tension pneumothorax. So these are very important features which are present in the patients of the tension pneumothorax, that is tracheal placement towards opposite side, bulging of the hemithorax, and patient might be hypotensed and his BP would be lower. This is the X-ray chest of a patient who is having pneumothorax. You can see this hypertranslucent lung field with absence of the vascular marking. These are the vascular marking you can see on the normal side, but no vascular marking are there in this area. In addition to that, you can see the border of the collapsed lung. This is the collapsed lung there, and you can look here, its border. In addition to that, you can see slight displacement of the mediastinum towards opposite side. So this is right-sided pneumothorax. CT is not routinely indicated. It is used in difficult cases to avoid misdirected attempts at aspiration. How will you manage a case of COPD? How will you manage a case of pneumothorax? So first of all, when the patient presents to you, you will look the features which favors tension pneumothorax, that is mediastinal shift or any hypertension. If these features are there, you will directly intubate the patient. Intercostal chest tube drainage should be placed, or if that is not, the patient is not at a place where chest tube is there, you will immediately go for needle thoracostomy. You will put a needle of any size which would be available there in the second intercostal space in the mid clavicular line on the affected side. There would be a gush of air from that area which would show that there is high positive pressure in the pleural space and there is tension pneumothorax. If these features are not there, you will assess whether the patient is having primary spontaneous pneumothorax or secondary spontaneous pneumothorax. If there is any chronic lung disease, you will again put an intercostal tube drainage or chest tube in the pleural space to drain the secondary spontaneous pneumothorax. If there is no chronic lung disease and patient is likely to have primary spontaneous pneumothorax, then you will assess whether the pneumothorax occupies more than 15% of the hemithorax or any significant dyspnea. If there is significant dyspnea or patient is having more than 15% of the hemithorax is occupied by air, you will assess whether the patient's age is more than 50 years. If yes, you will directly go for intercostal tube drainage. If the age is less than 50, you will attempt a percutaneous needle aspiration and would uh, aspirate at least 1.5 liters of air or more. If after aspiration of even 2.5 liter air, the pneumothorax still persists, you will go for intercostal drainage. Or even if after such drainage the patient is short of breath, then you will go for intercostal tube drainage. If the pneumothorax improves, you will keep the patient in observation for 6 hours All if there is minimal pneumothorax is remaining and patient is stable, you can follow that patient at outpatient facility. When you have placed a drain in the pleural space for the management of pneumothorax, it should be removed the morning after the lung has fully reinflated and bubbling has stopped. Continued bubbling after 5 to 7 days is an indication for surgery. If bubbling in the drainage bottle stops before the full reinflation, the tube is either blocked or kinked or displaced. So you will look are these differentials that if there is no column movement in the chest drainage or bubbling has stopped, there are four possibilities. Either the lung is fully expanded, or the tube is blocked, or tube is displaced, or it is kinked. So you will go for chest x-ray, fresh chest x-ray. If there is still persistent pneumothorax, you will look the position of the chest tube, whether that's displaced or not. If that is in place, you will watch the chest tube to look for whether that's blocked or kinked. If that's blocked or kinked, you will have to replace the chest tube. Supplemental oxygen may speed the resolution as it accelerates the rate at which the nitrogen is reabsorbed from the pleura. So high flow oxygen is given to this patient if there is no contraindication. Patients with closed pneumothorax should be advised not to fly. British Thoracic Society guidelines suggest that waiting 1 to 2 weeks after complete resolution of pneumothorax before flying. Patients should also be advised to stop smoking and informed about the risks of a recurrent pneumothorax. Diving is potentially dangerous after pneumothorax unless a surgical pleurodesis has sealed the lung to the chest wall. There are high chances of recurrence of pneumothorax if the patient has once in life a primary pneumothorax. There are 25% chances that he may redevelop that. Surgical pleurodesis is recommended in all patients following a second pneumothorax and should be considered following the first episode of secondary pneumothorax if low respiratory reserve makes recurrence hazardous. In addition to that, those persons whose occupation is high risk, like they are air hostesses, or their occupation is to fly the aeroplane, or they are divers. Ideally, after even first pneumothorax, fluidisis should be done so that chances of recurrence should be minimum in future. Thank you. This is all about pneumothorax. If you have any queries, you can ask at dr.istikhar@gmail.com.